Welcome everyone to our May webinar. I am Lynn Kinst, Executive Director of the Bleeding Disorders Council of California, and we are so happy that you are joining us this evening. Just a brief introduction for those that might be new to the Bleeding Disorders Council. We are a nonprofit organized here in California with around the shared advocacy agenda of the five California bleeding disorders organizations. We coordinate public policy issues that relate to healthcare and access to healthcare, particularly for people living with bleeding disorders. And we do a lot of partnership work through the California Rare Disease Access Coalition with other rare disease patient groups as well. Some of those folks may also be joining us this evening, and we're glad that you're here. So tonight we are so thankful to have Dr. Tomlinson with us. She is a board certified pediatrician and an educator. So she works in pediatric emergency medicine, but she also has a personal connection, which I think she's going to tell us a little bit about, to the bleeding disorders community. And so we felt like she was a great resource to bring in and talk about this issue of how do we access care when we do have to go to the emergency room. I know I've been around this community my whole life, and it's often a topic of conversation amongst patients and families of what a challenge it can be to get appropriate care when you go to an emergency room. This can be an issue for our rural patients as well as those that live in big cities even can also face this challenge. So excited to hear the presentation. I do again encourage folks, please feel free to throw questions in the chat as we're going. And then we'll have a little more time at the end to address any additional questions that people might have. So with that, I am going to turn it over to you, Dr. Tomlinson.
Awesome. Thank you so much, Lynn, for that introduction. And I'm very excited to be talking to you guys today. The ER is one of my favorite places to be, but not everybody else's favorite place. And so I'm hoping that I am able to provide you guys with some information about any anticipated or unexpected upcoming trip to the emergency department. I just want to thank the Bleeding Disorders Council of California and Lynn for inviting me here today. And I want to thank Carlos for interpreting for us today. And I want to thank all of you who are listening today. My patients are some of my biggest inspirations. And so I'm just really thankful to be able to chat with you. I just briefly, if there is a need for disclosures, I have a non-financial relationship with a nonprofit organization called Health Ed for Everyone. Our organization is aimed at improving health literacy and patient education. I'm currently the sitting board president actually, and some of the tools and techniques that I discussed in this talk were created as part of my role in that organization. We can skip this slide. Okay, so I just wanted to provide a little bit of introduction about myself, and let you know why I am the person talking to you today as opposed to any other excellent doctor. I am coming to you from Michigan. I work as a pediatric emergency medicine doctor. I trained in general pediatrics by residency and then pediatric emergency medicine in fellowship. And I currently work at the biggest children's hospital here. Well, I guess we're not the biggest, we're the second biggest children's hospital in Michigan, in Ann Arbor, at the University of Michigan. I also have married into the bleeding disorders community about 11 years ago now. I met my husband at our local bleeding disorders camp in Michigan for kids with bleeding disorders. And everybody always asks if he was a staff member or a camper, and he was definitely a staff member. I just want to say that. But I was able to volunteer there for for a rotation, and we met, and we've been together ever since. And so he has hemophilia, and this is my daughter Eleanor. She has hemophilia as well. So these are my two favorite hemophiliacs, and that's my connection to the bleeding disorders community. Lastly, I am just a very passionate advocate for clear and transparent communication, particularly in my job, but just anytime, anywhere. I love working in the ER, but in the ER, there are a lot of ways that communication can fall apart. It's a very chaotic environment. So I hope to kind of peel back the curtain a little bit and help you guys understand that. And I'm very excited that someone's been to the women's retreat because I actually did some of this discussion at the women's retreat last year. So some of this may look familiar to you if it was last year that you were here, Christina. Next slide, please. Oh, thank you. Okay, so I wanted to talk about preparing for an emergency department visit, which feels a little odd because most people think about the emergency department as I need care right now. This was very unexpected. I got in a car accident. I broke my ankle. It's like I think I'm having a heart attack. This is not something you plan for. But I think with people with bleeding disorders and other rare conditions, sometimes you kind of know when you have to go, or you're thinking about if you have to go or not, and then you make the decision to do so. And so you can kind of prepare a little bit. And I also think that when you are prepared, it just makes it feel a little bit more comfortable when you're there. So rather than try to, sorry, my cat's going to join us today. Rather than try to scramble and gather everything on your way out the door or ask somebody to find things for you, I'm going to discuss the top 5 ways I think that you can prepare for a trip to the ER, whether it's an anticipated trip or it's an unexpected trip. My first tip is an oldie but a goodie. It's really having some kind of like medical alert identification on your person. And this is especially important because not only does it, this is the biggest one for when you are unable to respond in an emergency, essentially. If you think of, you got into a car accident and you're unconscious, the emergency personnel who are seeing you at the scene are going to look for any kind of medical information on you. And so I have seen this in all forms. I'm just going to chat about a couple of them. One is the classic like medic alert bracelet or like a necklace or a tag or something like that that just says, I have diabetes, I have a bleeding disorder, this is my emergency contact, these are my allergies. I know like our local HTC will help people get access to medical alert bracelets. I know that's where my husband got his for a very long time. I also wanted to make people aware that on your phones, there is a section where you can write medical information, and that can be accessed by emergency care teams without unlocking your phone. So, from like the emergency call screen, at least on my iPhone, there is a small section where I can click for medical information, and I put in there information about myself, and then I also put my husband and my kids because I might be traveling with them, and if my phone is the first one they pick up, then they have the information for everybody else in the car. If you have an Android, I know there's another section where you can find that as well. So I encourage you to take a couple minutes to just look at your phone and put in an emergency contact, or put in your brief medical information there. Another thing that I've seen people do that I think is very unique and very helpful is posting some kind of placard in your car. Obviously, you want to protect your health information, but I think it can be helpful if in certain situations. One example is that I've seen people put like an index card on the plastic portion of the car seat that says this child has a seizure disorder, or this child has diabetes, or this child has hemophilia. And additionally, I've seen it for children who are like non-speaking, non-verbal, or autistic. That can also be helpful. And that just kind of alerts emergency personnel to when they go to take the child like out of the car, for example, they have that like just extra bit of information. And when we in the emergency scenario are piecing together information. Every little bit of information is helpful. And so any little piece of information we can have just makes our job that much easier. The second, the second idea that I have in terms of preparing for your visit to the ER is something that I have called a bleeding plan letter. This is not an this is not like a specific form. So if you go to your hematologist or your specialist and you say, I would like a bleeding plan letter, they don't know what that is because I made up that term. But what I mean by that is a letter that is written by your doctor that shows your diagnosis, shows your treatment plan, but also specifically how your disease affects you. If you have a rare disease that affects you in a very specific way, for example, you have a rheumatologic condition that causes increase in blood clots. I would want to know that as an ER doctor. And that's arguably the most important information that you could tell me about your specific disease. If you have severe hemophilia, for example, you may be more prone to bleeding spontaneously. Or if you have mild hemophilia, you may only bleed with severe injury, surgery, or something like that. That kind of information can be helpful for your average ER doctor. I know about different severities of hemophilia, but I can tell you that in my training before I married into the bleeding disorders community, I didn't know that hemophilia was a spectrum of severity, for example. So there are doctors out there who might not know that. Additionally, as we all know, women can be affected by bleeding disorders, but classically in training, we are taught that it is on the X chromosome, and so it typically affects men. However, we now know that it can affect women as well. And so you may encounter someone who doesn't, I hate to use this term, but like doesn't believe that you have a bleeding disorder. And so a letter like that could be particularly helpful. I saw in the chat someone commented that this is an emergency letter. And Christina, I do think that that would be similar to what this is called. Again, this is like kind of a term that I made up. And so I'm sure there are plenty of other terms out there as well. Okay, I'm going to come back to Loida's question in just a second. Okay, well, yeah. Do you want me to address questions as we go, Lynn? I can do it either way.
It's up to you. It's
Yeah,
totally up
okay.
to you.
Let's see. I would have to reach out to them during hours or pediatric hematologists after hours. Okay. Actually, I will say my next slide is about kind of emergency contact information. So we can go there. Emergency contacts, I think of, I always tell people make sure not only are they familiar with your medical history, but that they're also reliable. This is the person you want who's not going to screen their phone calls and will answer a phone call from an unknown number. I am not that person because I screen my phone calls, but I think we all know like people who do that and not do that. And I think that this would answer your question, Loida, is that I tell people like not only providing me with the phone number of your specialist, but also providing like after hours contact information. I've had a lot of patients where they're visiting from out of town, or maybe they were vacationing in our area, they got injured and they don't follow at our HTC, but they need to we need to contact them. And sometimes it can be hard when you're not in the same system to learn how to contact somebody outside. And I feel like as doctors, we might just be like, well, you can just call them tomorrow, which is honestly not the right answer. We should call and talk to them. And so if you can't get that kind of letter, having the contact information both for during business hours and after business hours would be particularly helpful for me to know how to contact people. All right, next slide. I get asked a lot about rare, like medications. Should I bring my medications to the ER? Should I just bring a list? What should I do? And I always tell people, when in doubt, just bring your medications with you. It can be kind of a hassle to like bring all of them, particularly if you have a lot of them. But in the instance of any rare medications, any injectable medications, factor replacement, anything like that, I recommend bringing them. One reason is because the emergency department carries an unknown wait time, and we don't want you to get behind on any scheduled medications. So bringing your scheduled medications can be helpful. The second is that we all know that certain Medicaid, like every hospital cannot carry every single medication. And I think that this is especially true in rural hospitals or what we call critical access hospitals. They can't carry everything in their pharmacy that, say, a busier urban hospital can. And so there is more of a likelihood that they will not have yours. They might have a factor replacement product, but not your specific factor replacement product. And so, similarly with any other kind of like anti, um, or sorry, I'm like any kind of like immune modulating medications, newer medications, things like that. So if you are on any of those medications, I encourage you to bring them. Another thing I've had people do is take pictures of all of the labels of your medicines and then create a folder in your photos of just your medications. And then that way you can like look them up quickly and find a picture of all of your medications. You can also take pictures of documents and put them in there as well. Or have like a physical list of all of the medications, the doses, and the frequencies. Sometimes people think, oh, it's just in the chart. You can check my chart. But I've had times where the medical record is not helping us or the medical record goes down, and it's always helpful to compare. And the other thing is that sometimes we find out that medications were prescribed incorrectly or you're taking them differently than they were prescribed. And that's an opportunity for us to clear up that question for you as well. Next slide, please. Thank you. My last tip is to create something called an emergency kit. And if you've ever had a baby or you had a partner who had a baby, you may remember this is like the baby bag. If you have ever taken care of anybody with like a tracheostomy, this is called a go bag. But it is basically a bag that is kind of like prepped and ready if you ever need it. And what I recommend that you include in there is copies of any important medical documents, like a emergency letter or a bleeding disorder letter, um, maybe a small supply of your medications, just like 24 or 48 hours of your medications that you can put in there and just have in there and they're like ready to go. Any rare medications that you need. I know a lot of factor needs to be refrigerated. And so in my house, we have a specific factor dose that sits on a shelf in the fridge. So I can just, any one of us can just grab it and take it with us. And then I also remind people to bring some comfort items. Like the ER is a loud and noisy place. Bring a phone charger. That's always the first thing people need. A bottle of, like, we have snacks and water, but if you wanted to bring like a bottle of water or like, some powdered something to add to water, if you want to bring like earplugs or an eye mask or something, the lights are bright, the sounds are loud, like anything you can do to kind of make your stay just a little bit more comfortable could be helpful. Okay, so this is the portion where I want to kind of switch gears before, or I'm going to switch gears and talk a little bit about communication and advocacy, specifically in the emergency department. I am going to just take like a brief moment if anybody has any questions and they want to unmute and answer, or they can put them in a chat. Bringing a blanket is a great idea. I'm currently in the portion of my life where I'm always having hot flashes, but blankets are a great idea for anybody else. Okay, so in this portion of my talk, I do a little bit of light teasing about doctors, and I apologize if I offend anybody, but I figure if I'm the doctor, I get to do a little bit of teasing. And what I want to talk about is why sometimes we encounter challenges with communicating with doctors as patients. It's because, in my experience, sometimes doctors are not the most flexible of thinkers. We can be kind of creatures of habit and stuck in our usual practice. The reason being is that when I think about my training, particularly in the emergency department, my training is focused on pattern recognition. And what that means is that I am taught to think about common problems presenting in common ways. I have left-sided chest pain that radiates down my arm, and I feel like an elephant is sitting on my chest. For me, that's a heart attack, right? That's the classic way to remember a heart attack. But what we often miss is some more subtle presentations, and we have to like learn those more subtle presentations as well. For example, in women, heart attacks can present as bad indigestion, nausea, back pain, things that you wouldn't necessarily think of as causing a heart attack, for example. And so we always have to kind of think about uncommon diagnoses and uncommon situations and how those are presenting in common or uncommon ways. Additionally, when we're taught by how to take a history from a patient, that means like how to ask you what's going on, what brings you into the ER today. That does we're taught to ask questions in a very specific script. Like I remember like the mnemonics that people taught us. And then you practice on a standardized patient, which is essentially an actor who gives you the answers that you're looking for if you ask the questions correctly. But it's not how real communication happens. And I learned this particularly in caring for children, that sometimes when I ask a question, the answer I get back doesn't match what I'm looking for. And so it requires me to dig a little deeper and ask additional clarifying questions to make sure that I understand what they're asking about. For example, if I asked a child, "Are you feeling nauseous?" They wouldn't know what that meant, probably. But if I then followed it up with, "Do you feel like you're gonna puke?" And they said no, well, maybe they don't use the word puke in their house to describe vomiting. So then I say, "Do you feel like you're gonna throw up?" And they're like, "Yes." And so you see how I asked the same question three times, three different ways, and I finally got to the answer I was looking for. And I recognize that what has gotten me to this point, you can go to my next slide. What has gotten me to this point is like my innate curiosity and experience to learn more about what people say to me. And so I've learned the importance of kind of moving away from that structured interview to more of a conversation about what's going on. And I think that um obviously I recognize I am not every doctor, not every doctor is me. And so you are going to encounter some situations where you are struggling to be heard or you're struggling to connect. And for the rest of the talk, I'm going to give you some kind of specific scenarios with some scripted dialogue that you can use to prompt a change in the conversation. Okay, the first scenario is a very common one. This is a scenario where you may need help with communication, whether that's like verbal communication or written communication. I think about patients who process things better auditorily, like listening, or people who process things better by reading. And sometimes in the ER, we're going to give you the information in one way. And if you don't I don't always think to offer it in multiple ways unless somebody tells me. And so I want to encourage you to feel like you can ask for those things. One thing, this first line is like near and dear to my heart because I have hearing loss and I read lips a lot when I'm not wearing my hearing aids. And so I often tell everybody they have to like look directly at me or point their mouth at my face so I can read their lips, or so I can hear them better. And sometimes I turn my ear so I can funnel all the hearing into like my ear. But if you are somebody who is hard of hearing or you're with someone who is hard of hearing, being able to say, "Hey, can you speak a little slower and face me or a little bit clearer?" Because sometimes speaking mumbly is really hard to hear. And also, a lot of places now will have masks that have an open window to them so that even if the doctor is wearing a mask, you can still see you can still read their lips if if they're talking to you. Sometimes I'll just pull my mask down and talk to people because it's a little bit easier too. The second point is about interpreter services. So hospitals are required to provide you with an interpreter in your language of comfort. And it is every hospital contracts with somebody to at minimum have a phone interpreter for you. You are welcome to say at the beginning, I don't need an interpreter. And then later say, just kidding, I actually do need an interpreter, or vice versa. I think a lot of people feel like if they got an interpreter, or if they said they didn't need an interpreter, now they can't ask for one. And please be empowered to know that you can. Also, if someone is trying to talk to you without an interpreter and you need it, just tell them, like, I don't speak English, or interpreter, please, or something where you can advocate for yourself in that way. Um, the following three statements are just about different ways of learning. I do better with step-by-step explanations. Please slow down. Can you write things down for me? I think writing down is huge. I am a mother to two autistic children, and oftentimes my kids can't process what I'm saying to them when I talk to them, but if I write them a note, they understand they can gather that information much more easily. And so a lot of people have differences in how they best understand. Oh, okay. Great question. What can you do if your primary care doctor refers you to a hematologist outside the HTC and that doctor isn't up to date on hemophilia in women? How can you get them to refer you to the HTC? So the first thing that I would do is I would ask this directly, and I would say, this doctor that you referred me to is not up to date on hemophilia as it relates to women. I would like to see an HTC. Can you make that happen for me? If they say no, or they're not in your network or something like that, then I would probably say, well, we can figure out insurance issues later. The other thing that you can do is groups like this group, right? The Bleeding Disorder Council of California, I'm sure has ways that they can help you get to the people that you need to go to. The other thing you can do is maybe contact the HTC yourself, or someone within the HTC, or a social worker, to see if you can make that connection happen. Those are a couple ways that I would kind of work through that. Christina, thank you so much for sharing your experience. I think it is so hard to have such an ultra rare disease. And even if the doctors and nurses and advanced practice providers, even if they don't know the specifics of your disease, they should be asking you how that presents specifically within you and how that affects you and your daughter. And I am sorry that you've had such a crappy experience, such a terrible experience. The next common scenario that I encounter is people who just need more information or want more information. It is never wrong to ask for additional information about something. I think we all recognize when people are experts in any given field, right? When I take my car to the shop, I know that they're experts in the field. I don't claim to know everything about my car and the funny noise it makes and like the oil being changed and like what oil is best and all of that. But I do see that person as an expert that I'm seeking information from. And so, in order to understand what they're telling me, I might need some extra information. And I might need to know, like, how is that going to affect me down the line if I don't change my air filter today? And if I do. And so I think similarly, when someone comes to me and asks me questions, it is my job to share my expertise with people. It is my job to make sure that you go away with with the correct and most accurate information that I can provide you. It is not I don't see it as somebody challenging me or like thinking they know more than me. I see it as an opportunity to have a discussion. And so, if you're getting a test, it is okay to ask why is that test like what is that test going to tell you about my symptoms, about my condition? How will I feel during the procedure, after the procedure? I find this particularly necessary, not just for children because they have a harder time like coping with things, but also adults. Like, I want to know what I'm going to experience before you do that to me. I remember one time I had to have um a I had like a pigmented lesion on my eyelid that I had to have removed. And the doctor just like came at my eye with this needle and like he was gonna numb up the area. And I was like, whoa, what are you doing? You're putting needles in my eye. Like, please tell me first. And so I just want you guys to know that happens like to me too as a doctor, like from another doctor. And so it's okay to say, I need a minute. Let's talk about this first, and then we'll get back to it. And so I want people to know that they can ask those questions. We can go to the next slide. I think this is particularly important for anyone who is a caregiver. If you are taking care of a child, a dependent adult, such as an adult child or like your adult child, or your adult parent or an adult like aunt or uncle, it is really helpful for you to explain things that only you may know. And I usually try to I usually listen to somebody when they tell me they can't speak for themselves, but this is what I'm noticing at home that's different. I'm noticing this kind of behavior that's different for them. That doesn't usually happen. I don't know what it means, but it's a different behavior than what they're usually doing. And I think the other thing in particular is the second bullet point here. If you have like an adult dependent who is maybe technically an adult and needs, for example, like a sensitive examination, it's okay to ask to stay if as long as the patient themselves consent so that you can be their support person. And I always encourage people to bring a support person with them or at least have a support person available because being in an unfamiliar place is very stressful. It's very anxiety inducing. Even if you don't have an anxiety diagnosis, it's still very anxiety inducing. And so it's very helpful to have a support person to help you in that moment. And my last slide is when you are feeling misunderstood. And I think that this can be really hard, especially I've seen a lot of people within the bleeding disorders community, outside of the bleeding disorders community, tell me that they have had bad interactions because they just don't feel understood. An example I can tell you from my personal life is one time my husband got into a car accident and brought his factor. His mom met him at the hospital with his factor. And he said, I need to take my factor right away. I got into a car accident, like I could have bleeding. And they said, no, you can't take it because if you take it, then we won't see the bleeding on the CT scan. And I was like, that's kind of the point, right? Like, you don't want to see bleeding on the CT scan. And so I think that he had a hard time in that scenario because he was like 19. He was technically an adult. He didn't know really how to navigate that situation. What ended up happening is that his mom is a nurse, and when the doctor left, she just gave the medicine anyway. And I'm sure you all, like many of you, have been in a situation like that as well. If you do that, just tell me. Like, as the doctor, I just want to know if you've taken something just so that I can make sure nothing that I'm going to give you will interact with what you've taken. But you have, in my mind, you have the right to take your own medications wherever you are. If you were shopping at like Walmart and you needed your blood pressure medication, you would take your blood pressure medication. Why is the hospital any different? So I just want you, like, I want patients to know that as long as they're like honest and as long as they tell me things that so that I have as much information as possible to care for you, that's all that I really care about. That is my last slide. I am gonna just like scroll back through the chat and there are a couple question. I don't know if I missed some question, but I'm happy to answer any questions right now. So thank you guys so much for participating in this talk.
Yeah, there was a couple of comments. I saw one was related to, I mean, we've had a lot of discussion about bringing the medication. You just shared an example of where they were like, oh no, you can't use that here.
Mhm.
Somebody in the chat had mentioned like a specific facility like won't let them use their medication because they want it to come from their own pharmacy, not from home.
Yeah. Yeah.
So any thoughts on that situation?
When that has happened in my institution, I have asked the pharmacist to look at the medicine and verify what's in it. So a lot of times the pharmacist can look at the prescription, look at the label on the box, and compare them and make sure that that is what it is, essentially. I mean, obviously, if it's loose pills in a box, like I can't tell what those are, but your factor comes in vials and each vial is labeled. And so we should be able to read the vial to know exactly what's on there. And that's where having the list of your medications and like your treatment plan is helpful because I can look at that and it says I take 2,000 units plus or minus 10%. And I can do the math and figure out if that's plus or minus 10%. And so I will sometimes ask the pharmacist to look at it. I will often like look at it myself too. But that's because I always say in my ER, I'm the bleeding disorders expert. And so everybody asks me questions about it. And so when I go in there, I'm like, I know more than this person or this person. So I just take care of it myself. But yeah, having the pharmacist verify medications is what we do in those scenarios.
Yeah, that's great. And I think that's also why I mean, I'm not a hematologist, but I think that's a lot why a lot of our HTC doctors will say, if possible, and you believe you're having a bleed, like call us, treat, and then go to the emergency room,
Hmm.
right? And so
Yeah. Hmm.
they'll often say, call them first. They can tell you, yeah, go ahead and infuse and then
Hmm.
go. So
Yeah.
you get that first dose on board before you get to the situation where you're setting in the emergency room,
Yeah.
and you may or may not have an issue with them like wanting to accept that medication. I would also say like if it's something that they have in the hospital pharmacy and they want to give you that instead of what you have, that's not an issue as long as you're
Yeah.
getting what you need, right?
Absolutely. Yeah. And
There
I've
that's
done that
def
before where I've told people, hey, save your stock because sometimes, with medications, you get a 30-day supply. Well, what happens when you're in a 31-day month, right? You're technically a little short. And so it's always, in my opinion, helpful to kind of be ahead of your refills. And if that's another example of where I can say, like, oh, save like one extra of your like Tacro or one extra of your blood pressure medicine or your immunosuppressant or something like that, then I try to do that for patients and say just use our stock. Unless it's going to take forever to come from the pharmacy. And then I'm like, we'll have a different conversation.
yeah.
Oh, I have a
Um,
question.
yeah, go ahead.
So what would you recommend? So like in my case, we are in a rural area. So the closest we have two major hospitals that are close to us. Both have emergency rooms. Both are about 30 minutes away from us. However, one does not have a my son is 5. One does not have a pediatric department at all
Hmm.
whatsoever.
Hmm.
So we are always referred to the other. But
Hmm.
that hospital does not have a pediatric hematologist at
Hmm.
all.
Yeah.
Um, so we did have to go there once. Um, and we waited about 4.5 hours. And when I finally came out and said, "You no," I think it was like more like 5.5, 6 hours. We were there for a really long time. And
Hmm.
I came out and I finally, after having come out a couple times and said like, hey, what's going on, they finally told me, well, we don't really know what to do with him,
Mm.
so just sit tight. I'm like, no, we're not gonna sit tight because now
Yeah.
I know you guys have no clue what's going on or
Hmm.
what to do with him or anything. And
Yeah.
at that point he did not have he wasn't getting regular factor. He was just on
Hmm.
him Libra. we didn't have any medication for him whatsoever. So
Right.
really, we were new to this as well. So we didn't know what to
Yeah.
do with him either. But
Hmm.
we were kind of stuck.
Can
Yeah.
I ask a follow-up question?
Yeah.
Because you had made the comment in the questions that you hadn't been able to get a letter from your
Hmm.
hematologist. Are you able to be seen at a hemophilia treatment center, or is it another hematologist that you're going to?
So we have Kaiser.
Okay. And where are you in California?
Yeah.
Where in California are you?
Southern California. So the closest hematologist, like his actual hematologist that he's assigned to, that's the closest to us, is an hour and a half away.
Hmm.
Okay.
With given traffic, it's about 2.5 hours.
Yeah. I will follow up with you offline because I
Okay.
will say that one of the things that we are working on right now is collecting stories from Kaiser patients. We've had a
Okay.
lot of issues with Kaiser not
Yes.
providing appropriate access to care for bleeding
Yeah.
disorders patients. And so we are currently collecting those stories because we have a contact at Kaiser that
Mhm.
is going to be taking that back and working on hopefully improving things. So when you made that comment, I was like, that sounds like Kaiser to me, but I'm not going to
Mhm.
assume because I don't
No,
know if
yeah.
there's not a single affiliate treatment center in California where I think you would have gotten that response. It's pretty standard to like
Yeah.
draft those emergency letters.
Yeah. He developed an inhibitor about a year and a half ago. When we finally did get factor, he got injured, got 2 doses of factor um in that injury, and then instant inhibitor. At the
Mhm.
second one, the second dose did nothing. It was basically infusing him with, saline. His body did not accept it. And so I actually would prefer speaking to the hematology pharmacist.
Mhm.
She's a huge help. His hematologist, he's 5. He stopped Hemlibra when he got the inhibitor almost 2 years ago. When I talk to her, she still asks me how it's going on Hemlibra, and he hasn't been on it for almost 2 years.
Is
So
that
I'm kind of
Ronnie?
like, I love Ronnie. Ronnie is the best. His hematologist, not so much. Ronnie, I know that I can call and I can leave a message, and even if they're off, she'll still call me.
Gotcha. All right. Well, we'll follow up
Yeah.
with you on all of that
Okay. Okay.
and see what we can do to help. I know we're a bit over time already, folks, and so I appreciate so many people hanging in there. Um, I do want to see if anyone else has any questions before we wrap things up. I appreciate. Thank you so much, Sarah, for sharing all these tips. I think these were a lot of good suggestions for folks. And again, for those that if you do have California specific issues, I know there was a couple things that came up related to, access to hemophilia treatment centers or like this issue we were just talking about with Kaiser. Please do reach out to me directly and we will be happy to see what we can do to help you navigate those specific issues.
I have a question on advocating for IV placement with really difficult veins, especially in the ER. And I was just wondering if you have any thoughts on that. I know we're over time, but just
Yeah.
on not having a support person and having multiple traumas as a result of that,
Mhm.
and you know, or
Yeah.
anything.
That's a great question. I think it's very um it's multi-layered, and I like from the perspective of the care team, from like the medical perspective and from the patient perspective. I think when I will tell you guys, I think when people say oh, like I have a hard time or I'm a hard stick or something like that. There are some people who are like, challenge accepted. And I am going to like get this IV that nobody else was able to get. And I think that that's kind of similar to like if someone said to me, like, I have never been able to cook a roast chicken before without like it being dry. I would be like, challenge accepted. I have a very good roast chicken recipe, you know? And, but it's obviously like much more high pressure, much more high stakes when we are talking about humans and human interaction. And so I think, that you've probably encountered people who have said, "Oh, I'm really good at this," and then proceed to muck it up, you know? And I'm
Yeah.
sure, yeah. So I'm sure that that has happened. I think,
And, barring not going to IR, like just,
yeah.
like,
And so
obviously.
if there is something that has been successful for you in the past, one thing that I tell, like that a lot of parents tell me is we have more success with ultrasound guidance IV placement than without.
Hmm. Yes.
And kind of asking for that like right off the bat can be helpful, or knowing
Okay.
like this is the spot that tends to be my go-to, or people have like found it here last time but not here. And I think just, and I just kind of say, I'm not trying to be difficult. Like, I just know that I've had a lot of bad experiences. And is there anything that we can kind of do to try to help minimize some of that, like, anxiety for me? Can we like turn the lights down? Like, do you have, like, are you okay if I listen to some music while I do this? In pediatrics, we have some things we have like these vibrating toys. It's called like a Buzzy Bee, and we put that above where we're doing the IV start because that helps to change the brain's perception of what's happening in that extremity in that limb. And so that is something that you can also like buy on Amazon, and it could be something that you bring with you as one of those
Oh,
comfort
wow.
items to say like this has helped me before. I also use these things for my kids called shot blockers, which is a little piece of plastic, and it has like little like pokey things on it, not like hard, but it interrupts the pain signal by being more of a pressure signal. And then there's a hole in the middle where you put the injection in. And so I use that for my kids for their vaccines, and it works like decently well. And so I think like this is why I encourage people, like we have a lot of things that we do for children, but like adults need these things too. And it's okay to ask for that. And, I always like, I never want people to feel like, oh, I just like, you just have to sit through it, like that's not helpful. That's not how we cope as people. It's not really good
Thank you so
medicine.
much.
You're welcome.
Invaluable talk. Really appreciate your time.
Thank you.
Great, great tips. Some of those are brand new for me, so I love that. Um, sometimes yeah, there's just a comment. It can be hard to advocate for a new person. But I think um it's important to go ahead and speak up. And I think most of the stuff in the ER is like not going to be offended by that, right? Like I've seen lots of nurses be like, "Hey, I'm having a hard time with this patient. Can you come over here and do this or whatever?" It's unfortunate when you do get that person that's prickly about it, but
I think that a lot of places too are starting to develop like a pathway for specific difficult access. So we have my hospital is developing a pathway for difficult access where the nurses themselves, one person will try 2 times to get an IV, and then if they can't get it, they then have like a path that they escalate up to someone else, whether that's like a different clinician, someone who does ultrasound IV guidance, a specialized IV team in the hospital, an ICU nurse. There's like a whole set of pathways. And I think a lot of places are starting to think about how can we share the resources in the hospital to be the most like successful with the least amount of attempts. Because there's a reason I'm the doctor and not the nurse. I can't just sit there and poke kids all the time. I feel bad.
Exactly. Anyone, any last questions before we wrap up? All right, this was a really great discussion. Thank you so much for your time. I think the fact that so many people stayed way past the time tells me how valuable everyone thought it was. So, appreciate you all joining us and hanging in there for the Q&A, and we look forward to more opportunities. I had the screen up. We'll take the next couple of months off of our webinar series during the summer, but we'll pick back up in August. So hope folks will rejoin us then, and have a great rest of your evening. Thank you so much.
Thank you, everybody.